take a short description about COVID management. Then we see together our objectives. After that, we are going to talk about training and laboratory testing, IPC measures. We are going to detail the confirmed case management. After that, we are going to see how a death with COVID-19 is managed. After all, we take a short conclusion. Next. The COVID-19 pandemic is caused by a newly emergent coronavirus. We know that. And this coronavirus was recognized in China in December 2019. These viruses is primarily human-to-human transmitted by direct contact or indirect contact. While this COVID-19 is primarily a pulmonary disease, it is a posing unprecedented, challenging, and treated to patients a healthcare system worldwide. That's why we are going to see the management on COVID-19 as a holistic and a multidisciplinary team for a good outcome. Next. Next. Our objectives for this course, the first of all is to know when to suspect and how to make the positive diagnostic of COVID-19. When am I going to suspect a person and how I make a positive diagnosis? The second point for our objective is to know the IPC measures required when we have a suspect or a positive case. The third point of an objective is to recognize the stage of severity of COVID-19, their manifestation, and how to treat them. Globally, those are our objectives in this course. And at the end of this course, we expect that all of you will be able to provide an optimum care for all confirmed patients. If you meet a patient who is confirmed positive, we think we will be able to give an optimum care for that person. The other thing which I expect that everyone will be able to do is that everyone will protect himself and will be able to protect our client, so we will slow the transmission of this COVID-19. Next. So when we are talking about a suspect person, I think yesterday we talked about it. A suspect person is any person or any patient with any acute respiratory illness. This could be a fever, but this fever must be associated with only one or many symptoms like a cough, shortness of breathing, throat, and the other symptoms of respiratory disease. When a patient comes and you found fever and cough, this person is a suspect case. If you found a person who has fever and the shortness of breathing, this person is also a suspect case. If you found a person with fever of history of fever with rhinorrhea, this person also is a suspect case. Let's go to the probable case. A probable case is that person that you've already suspected, and when they did a test for that person, the result is presumptive. A test which is presumptive, it means that it's neither positive nor negative. This is a first person who can be probable case. And then you can also take a probable case as a suspect person or a suspect patient that you couldn't perform the test. For example, sometimes patient like the patient who are unstable with mental illness, sometimes it's difficult to make a testing until you will be able. Hello, you hear me?
Yeah, we can hear you. Yes.
Okay.
The voice was lost for a few minutes ago, but maybe you can go on the probable case.
Probable case, right. So a probable case is any person that you've suspected, and then you've done a testing for COVID-19 and the result was presumptive. The result which is presumptive, it means that it is neither positive nor negative. This is the first case of probable case. You can also say a person is a probable case while the person is suspected, but you couldn't take any sample for this person. I gave an example for a person who is agitated, unstable, who is aggressive, and he is also suspected. In that condition, you are not able to take a sample for this person. You are not able to test this person. So this patient who is suspected and unable to perform the testing is considered as a probable case. A confirmed case is that person which laboratory testing confirmed the COVID-19 infection. This is a confirmed person. And we can also talk about a contact person. A contact person is that person who had a contact with a COVID case. It means we have two persons, we have A and B. When A is positive, COVID positive, and you have the person B who met person A from 72 hours before the onset of symptoms, we say that this person B is a contact of the person A. We also say a contact is a person who we can have a person A who doesn't have any symptom, but he is a confirmed case. And when this person A is positive without symptoms, we can say the person B is his contact when they have met in the 72 hours before the taking the positive test of the person A. I think I don't know if you have already understand the difference of the two cases, the two possibilities of contact person. I need your comment here.
Hey, maybe, Doctor, maybe we can ask people to comment in the time dedicated for questions and answers towards the end.
Okay, no problem.
Let's go on. All right.
Then we can go on the next. Yes. So after defining those different category of person, which will be the element, the key for our course, let's go to see what are we going to do after defining our patient. If we have categorized our patient as a suspect or a probable person, this person will give him immediately a surgical mask to protect, and he put on to cover the mouth and the nose. Secondly, we isolate that person in a area which is well located and take the sample for this suspect or probable person. After that, when we have results and we know that it's already a confirmed person, we cohort this person in an appropriate room or appropriate area and start a treatment accordingly to his condition. We don't have to forget that we consider all comorbidities and all co-infection that could have be with our patients. On this pathway of COVID care, we can see when a person, the person can come to the hospital. The person, she could come on pharmacy, or the person could come on a clinic. When he arrived there, we can categorize that person. If this person is a suspect, when this person is a suspect and we are in any hospital or any clinic, immediately as a team, we are considering that person as a person who could transmit the infection to other people. So we give him, as we said, a surgical mask. For the caregivers, we have to respect the IPC measures by using PPEs accordingly to the case. After that, we assess the patient clinically. After assessing the patient clinically, we can either recognize, for example, the person on the entrance, we found the fever, but there is no other symptom related on respiratory tract. For this person, we can release this person because he's not suspected. There is no respiratory sign which is related to, which is accompanied with fever. When this fever is with, for example, with cough and rhinorrhea, for example, this person have to be tested. After testing, we will decide if this person is COVID-19 positive or he is negative with the result of the laboratory. When he is negative, we can release the patient and go back home, educate the patient for the measures to do arriving home. If the person is positive, there are many possibilities according to the severity of the patient. There is patients who are going to be oriented to their home, but in isolated room in their home. There are people who are going, for example, depending on the facilities or the country where they are, they will be in a community placed. Hello?
Yes, we can hear.
Hello? You
Yes,
hear
we
me?
can hear. Yes, go ahead, please.
Okay. There are people that can be oriented in facilities, community facilities where they will rest. There are other patients who will be oriented in treatment center according to their condition at that moment. After in this area of giving them care according to their clinic condition, after 10 days of symptoms onset, this patient can be released, or 10 days after the positive testing. This means a patient who who was asymptomatic and was positive, we are going to take 10 days after the positive testing to release him, go back home with education, of course. And the person who was symptomatic, we will take 10 days after the onset of symptoms. Next. Let's see how the laboratory testing is performed in COVID-19. This testing is performed on a suspect or a probable case, either on a high-risk contact with a COVID-19 patient. For example, we have two persons, person A and person B. They have been in contact in the last few hours before the coming to the testing, and the person A became positive, while the person B doesn't have any symptom or doesn't have any complaint. This person B, who was in great touch with the person A, is at a high risk contact with a COVID patient. This person also can be tested. The laboratory testing can be also done to special cases, for example, for exposures, healthcare workers, those who are working in treatment centers, the support staff, for example, the cleaners who work at hospital, who are always around hospitals, travelers, when people want to travel and take the plane, you know that those persons also can be tested. Those are the categories of persons who can be tested for COVID-19. We have two ways of testing. We have the first one, which have been used since the first cases. It is using the nucleic acid amplification test using the PCR. This is the standard and effective since the 5th day after exposure. It means that on the 5th day after exposure to the virus of COVID-19, with the testing of PCR, we can give a positive result. But a negative result doesn't exclude the positivity. This means that after the 5th days and the result is negative, we can repeat it few days, 3 days later, and then we can find a positive result. We have also another way of testing. It is an antigen test, which is less sensitive when the person or the patient don't have symptoms, but it have the similar high specificity as the PCR testing. This means that when we have a patient who has symptoms and you perform an antigen test, it will have a good specificity result as it was a PCR testing. But when you perform an antigen testing or rapid test to a person who is asymptomatic, several times the result will be negative while the person was positive. About in collecting the sample is collected in upper respiratory tract. This is the main way which is used, and especially the nasal swab. Behind the nasal swab, we can also do a oropharyngeal swab. There are many few testing which have been done to saliva, but in our country here in Rwanda, we only use the nasal swab and the oropharyngeal swab. In some cases, we can do lower respiratory tract. We can take a sample for lower respiratory tract, and this can be by endotracheal aspirates. Mainly, this is for persons when they have symptoms, and those symptoms are are positioning that person as a probable case, but with the sample collected on upper respiratory tract, which is negative, that's when we can do a lower respiratory sampling. Next. So when we have a result, when we have a positive result, the patient is admitted in appropriate area or appropriate room according to his condition, and we start the follow-up for this patient. When the result is negative, the patient is discharged at home and educated to follow all public health measures. And when the result is presumptive, the patient will be retested after 72 hours and confirm their status. It means that after 72 hours, we will repeat the test, and it has been found that 30% person will be positive, which is not small number. Next. So let's talk about IPC measures. When we have a suspect patient or a confirmed patient, the first thing to do is to give him a surgical mask. When you have a patient on emergency or on OPD, give immediately a surgical mask and then isolate him in a single room. If there is not a single room, you can orient him in a shared room, but you have to space beds of patients. And then you have to educate to perform hand washing. For healthcare providers, we have to use appropriate PPEs. Here I've listed a lot of type of PPEs that we have to use accordingly to what we are going to do, when, and if the person is suspected or confirmed case. And behind that, we have to follow the procedures of donning and doffing. It means that when we are putting our PPEs, we have to follow the structure that have been given, and we have to wash our hands after removing the PPEs, because all these PPEs, we don't know if we have touched any area which contaminated. We don't have to forget environmental cleaning and waste manager staff, which also have to use the PPEs according to the waste they are going to collecting or the place they are going to clean. Next. Next. We have, as health providers, we have also to follow the environmental measures, which is to make a regular cleaning and the decontaminations of room and equipment and surfaces and clothes. We have to clean regularly, especially the place people visit the most, the place where people gather. Those places have to be regularly cleaned and decontaminated. We have to use hospital disinfectant with sodium hypochlorite and ethanol. Also, all wastes are treated as infectious clinical wastes. All wastes that we have in the isolated room or the place we have our patient who is suspected or confirmed COVID-19, all those wastes are considered as infectious clinical wastes. On the other part, we have to perform hand hygiene frequently by washing our hands with soap and water for 40 to 60 seconds, or cleaning our hands with alcohol solutions and gel. But what is most recommended is to wash hands with water and soap. We have to perform hand hygiene also before donning and doffing and after contact with potentially infectious material. For example, when you receive a patient you suspected, and we have collected many samples, you have collected blood samples, you have collected also the sample of COVID, all things that are already there you've touched are considered as infectious material. When you are doffing and after doffing, you have to hand washing. When you have COVID-19 patients, suspected or probable or confirmed, visits are restricted. They are not allowed. Let's go to management of confirmed case. Clinically, we have most symptoms which are there. The most symptoms that we can find is fever, but we have to make attention with fever because sometimes people out there, when they are fever, they go to pharmacy and take paracetamol. They don't care about other symptoms, or other symptoms will come after. But fever is the main symptom which we found in these cases. We can also find cough, fatigue, anorexia, shortness of breathing. Those are the main symptoms we found in these cases. But there are also other symptoms which are not specific, like nasal congestion, headaches, diarrhea, nausea, vomiting, loss of smell, loss of taste. Those are the not specific symptoms you can find in those cases. And all people and immunosuppression patients, they always or they usually have no specific symptoms, and they used to have fatigue or reduced alertness, and we don't have to check the main symptoms for those people. Children, they have less fever and cough. They used to have nasal congestion and vomiting and nausea. What are the risk factors for severe disease? When we have a patient who is above 60 years, this criteria puts him in persons who can develop the severe disease. When we have a person with existing non-communicable disease, which is known, also this is a risk factor for severe disease. The pregnancy and smoking, those are the main risk factors for severe disease in COVID-19. The stage of severity. I've used to say about asymptomatic patients. Sometimes we can have asymptomatic patient, but when we have a symptomatic patient, it could be a mild disease. Mild disease, it means the patient have few symptoms, one or two symptoms, or that we have described before. For moderate disease, we have already clinical of pneumonia, which are fever, cough, fast breathing, dyspnea, but we don't have any sign of severity. When we talk about severe disease, it's when we have a pneumonia which starts to be complicated with distress respiratory, with tachypnea, where the respiratory rate is above 30 per minute. When we start to have hypoxia, it means that SpO2 is below 90%. Then you can start saying this person is developing a severe disease. The last stage is the critical disease, where the patient can develop sepsis, shock septic, or acute respiratory distress syndrome. In those cases, the patient are in critical cases. Investigations. Normally, at admission, any person who came who is positive case, we ask a full blood count, CPR, the liver function, the renal function, and the chest X-ray. Those are the main investigation we ask for everyone, not depending on the severity of his disease. When we have an asymptomatic person or a person who developed a mild disease, we just ask for all the exams, and in general, there is no specificity in the laboratory or in imaging. But when we go about moderate disease, we found abnormality in lab analysis and on chest X-ray. This chest X-ray is showing a reticulonodular opacity in both lungs, which is found on a patient who developed a moderate disease. This is an image of a pneumonia which is not yet complicated. Next. Next. For severe and critical disease, the investigation, in the best investigation, we add blood gas analysis, we add inflammatory markers as cytokines, EKG, echocardiography is the main to see, for example, for a person who in shock septic, if he doesn't developing a heart failure. We can also perform a CT scan, a chest CT scan. On that image, we can see how the image can be various. On the A image, we see the grounds glass opacity, which are in both lungs. I think you are seeing them. On the image B, we are seeing consolidation in both lungs. In image C, we have consolidation with ground glass opacities in the right lung. And on image D, you see a solid nodule in the left lung. So we see that the radiography can be in various images, but those are the mainly where the images can be found on radiography. This is the image of chest CT scan. Next. After viewing the manifestation of each stage, let's talk about the treatment. In general, the treatment is accordingly to the severity, but it is crucial to, first of all, to identify the severity of the case, which will help to monitoring the patient and to orient this patient in appropriate room and give him, for example, for a person who needs oxygenation, this will be, he will need oxygenotherapy. Also, it's crucial to identify the comorbidities, and the treatment of these comorbidities will be started simultaneously with the treatment of the COVID-19. And the other thing which is important in the treatment is to maintain an appropriate hydration for those patients and adequate nutrition for COVID patients. This is very, very important for our patients who are COVID-19 positive. For asymptomatic disease, there is no particular treatment which is given to this patient. We just tell them to isolate themselves at home or to take a room which is apart. We have to daily monitor the vital signs to see if there is no sign that will start. They have to implement the IPC measures while they are, and they have to wear a surgical mask every day. For mild and moderate disease, next. For mild and moderate disease, we self-isolate the person who has a mild disease, and the person who has a moderate disease, they have to go in the treatment centers. As others, we have to do a daily monitoring to detect the worsening of the disease. They have to wear a mask and to do with the IPC measures. For those who have symptoms, we give them the symptomatic treatment, which is hydration, the antipyretic like paracetamol, efferalgan, and others. Vitamin C, we can give them any decongestion, or we can give them the cough mixtures. It depends on the symptom they have. If we think the person has a bacterial pneumonia, for people who developed pneumonia, we can start antibiotherapy. And in those cases, the antibiotic we can use, there is doxycycline, either amoxicillin or augmentin. Those are the three antibiotics we can start with in the mild or moderate disease when we are suspecting a bacterial pneumonia. In this disease also, we start a prophylaxis, DVT, for patients who are hospitalized. It means for patients who has a moderate disease. Next, for severe disease, when you assess a patient, you categorize him as a severe patient. We admit this patient in COVID-19 treatment center. We give them oxygenotherapy because we noticed that when we talk about severity disease, it means the patient start to have hypoxia. And the oxygenotherapy, we can use the nasal prongs or the regular oxygen mask or the non-breathing mask, depending on the condition of the patient. We have to respect IPC measures as health providers, because here we have a case who is very, very ill, and we have to protect us very well. In those cases, steroids are systematically given, and in this case, we gave them dexamethasone principally, but we have two others alternatives, which are prednisolone and hydrocortisone. Antibiotics, they are given for 7 days, and we can give them either augmentin with clarithromycin, or we can give them cefuroxime and clarithromycin, or we give them ceftriaxone. When we have a patient who is allergic to penicillin, we give them levofloxacin peros. This is the treatment in severe disease. The DVT prophylaxis for these persons is given systematically, and a therapeutic dose can be given when the inflammatory markers are higher. For example, when we have a CRP which is increased, or when we have a respiratory rate which is below 24 per minute, or when we have a SpO2 which is below 90%. In those cases, in severe disease, we can give them antiviral therapeutics, and the first one which is recommended, have been recommended, is remdesivir, which is given intravenously, and we give it until the clinical improvement for the patient. Actually, in Rwanda, we have already a treatment which is an antiviral therapeutic, but it is the favipiravir. There are the tablets which are used, and we give them 9 tablets BID the first day, and then we give them 4 tablets BID from the day 2 to the maximum for 40 days. You can give them between 7 and 12 days for this treatment. This favipiravir, this is the one which is already started to be given in our country, in our treatment centers. But to give this treatment, we have to have a monitoring of renal and liver function. Critical patients. Our critical patients are admitted in ICU in treatment center, of course. Oxygenotherapy is generally mechanical ventilation, which could be a non-invasive ventilation or an invasive ventilation. This mechanical ventilation is when we give oxygen under positive pressure. Then we give to our patient a maximum volume of oxygen. And when we have a critical patient, we will need vasopressors to support, especially in patients who have shock septic. We can also give them steroid, as we've said. Principally, we gave them dexamethasone, but we have also alternative of prednisolone and hydrocortisone. We gave them a therapeutic dose of anticoagulant. We don't treat as a prophylaxis here. We give them a therapeutic dose, and we gave them antibiotic in severe disease. And the antibiotic we use here, we use ceftazidime intravenous 2-gram TID for 7 days, or we give levofloxacin when we have a patient who is allergic to penicillin. For critical patients, we can also use specific antiviral therapeutic, but with a precaution and close monitoring for the renal and hepatic function. When we perform resuscitation for patients who have septic shock, we give them crystalloid fluid, means normal saline or lactate. And then the target is to have a MAP which is above 65 millimeter of mercury and have a good urine output and have an improvement of skin. But we have to make a short attention. We are doing a fluid resuscitation because it may lead to a volume overload, and this volume overload can lead to respiratory failure and heart failure. So when we are doing a fluid resuscitation, we have to be careful. Next. When we see this patient who is here, we see a patient that we have diagnosed COVID-19, and he has fear, he is worried, he has anger, he is frustrated, he is thinking about many things here. So as healthcare provider, we have to do something. We have to do something to make them to feel that that they can be well. Next. So to shift from the first image to the second image, we have to help our patient. We facilitate communication first. Facilitate communication with his families, his loved ones, with friends, with his colleague, by phone, by internet. We can also help him to share his or her concerns and feelings with others, because if he doesn't change his feelings, this person, he will remain in his worries, he will remain with his boredom, he will remain with his problems. The other things we have to do is to keep him or her informed. What is going on? What is the next step? What is the prognosis? To inform him or her what is going on. This will help him to be calm. Another thing, we have to take care to help them to take care of their own body. What are we supposed to do there? we are supposed to initiate a healthy nutrition, a physical exercise where it is possible, to have an adequate sleep. Those things will help him to 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 recover quickly, but also in his mind he will be calm and quiet. When the patient, when we talk about healthy nutrition, it is recommended with to avoid processed nutrition or processed diets. We have to do fruits, legumes, to drink water, and the physical exercise is very, very important for our patients. In some cases, when we have a patient who has anxiety and we are not able to control this anxiety, it's sometimes possible we can shift to counseling and psychotherapy. And when it's not possible, we can use pharmacotherapy, we can use drugs. All depends. But all we have to do is to do our best to transform the first person we had to the second person we have here, who is happy, who is happy. Next. Next. The management was for patients who have been COVID positive, but we don't have to forget the healthcare providers who also can be stressed during the activity they do, facing patients and so on. So managers should keep all the staff protected from chronic stress by encouraging them, by regularly supporting them, and monitoring the staff for their well-being. This is the task of managers. I hope among us there are also managers. So will be the task for that. Next. There is a short particularity for women who are pregnant and the neonates. We don't have any evidence that there is a transmission between mother and the child during the last term of pregnancy. And we know also that COVID-19 may increase the risk for pregnancy complication. So when we are taking when we are taking care for a pregnant woman, we should give her optimal health care to protect either the mother and the neonates. All healthcare workers who can be in the delivery room should adhere to IPC recommendation, because we know anytime contraction can come, anytime a baby can come. So all healthcare workers must be ready and adhere on IPC recommendation. During delivery, the immediate skin to skin is not recommended. After delivery, it's not recommended to put the baby on the skin of her mother. The neonat team, which is ready to take off the baby, have to take a minimum distance of 2 meters from the mother during the delivery. So this will also avoid the contamination of the neonatal team, which could contaminate the baby. So this team could maintain this maximum 2 meters of distance. And Before the birth of the baby, the health carers have to explain to the mother the benefits of milk, the breast milk, and the benefits of breastfeeding, and the need of IPC measures when it will be time of breastfeeding. So it will not be difficult to them or to her after delivering. Normally, the baby should breastfeed within 1 hour after birth. For all newborns, a test of COVID will be established on after 24 hours and 48 hours after birth. This is another particularity for neonates. Next, about discharging our patient. To discharge our patient, we have two criteria. We have a test-based criteria and we have a symptom-based criteria. A test-based criteria is when we have a negative result of COVID-19, which is obtained 7 days counting from the day of positivity. And the symptom-based criteria is when we have a symptomatic patient. When it is about a asymptomatic patient, we can discharge the patient 10 days after the positive test. And for a symptomatic patient, we can discharge him 10 days after the symptom onset, plus at least 3 days additional without symptoms. For example, if we have a patient A, he has been admitted with cough and fever and congestion, but we noticed that on day 9 he still have congestion. This is the last day of congestion. On day 10, it is the day of the 10th day of symptomatic onset, but we cannot discharge him on the 10th day because we have to count at least 3 days without symptom. And days without symptoms, here we have only 1. On that patient, we have to add 2 days before discharging him. I think we have already understand the 10 days after symptom onset and 3 days without symptoms. Next, death with COVID-19. Well, how to manage when we have death with COVID-19. We have to know that this virus may stay alive in all body fluids for a long period. We don't know exactly how many, but these give a risk of transmission which is high as in a confirmed case patient. That's why any dead body is potentially infectious and standard hygiene precaution must be applied on this dead body. So when we are preparing of the disease, when we are doing preparation of disease, like cleaning the body, tying of hair, trimming of nails, and so on, the person who is doing that must wear an appropriate PPE. And we have to apply the principle of cultural sensitivity, of course, when the family wish to view the body after its removal from isolation or related area. They can be allowed to do so, but they have to be protected. They have to wear PPEs. They don't have to touch or kiss the body. let's take a short conclusion. COVID-19, it's a viral infectious disease which can be fatal for everyone, especially in high-risk population that we have mentioned. And also, IPC measures are the key to reduce the transmission of COVID-19. The management of this disease is multidisciplinary and concern a holistic approach for the patient. My reference was taken in the COVID clinical management guideline from RBC, clinical management on COVID-19 from WHO and CDC site and WHO site. Thank you very much for your attention. I think you've catch or you've learned something interesting in this course, and I can give the floor to Alan. If there are some questions, they are very welcome and we can discuss them together. Thank you.
Sure. Thank you very much. Alan?
Thank you so much, Dr. Anita, for the lecture, and we really learned a lot from it. Since we are already time bad, I think we'll read the questions, but I'd like first of all to thank Dr. Steve Kaze and Dr. Daisy Omotoni. They've been helping us in the chats and answering some of the questions that the participants asked. So thank you very much. So I'll read the questions to Dr. Daisy. Then, yeah. So one of the questions was, why do you think, sorry, yeah, ni gute usanga abantu batanganya igihe bamara kwa muganga iminsi? That was one of the questions.
Can I answer? Can I take a list of some questions and I answer together?
Yeah, so I don't know if I should paste them because there are so many in the chats with, of course, the.
Okay, nta kibazo. Donc, abantu gute batanganya igihe bamara kwa muganga? Sinzi bisobanure mu Kinyarwanda, nta kibazo?
Yeah, nta kibazo.
Okay. Ni ukuvuga nk'uko twabibonye, umurwayi ashobora gupimwa uyu munsi ariko ibimenyetso bimaze aribwo bigitangira kuza. Niyo mpamvu umurwayi iyo yaje turamubaza se ibimenyetso byatangiye kuza ryari. Icyo ni kimwe. Ikindi cya kabiri tureberaho ni ukureba ese ibimenyetso bye yagize byarangiye ryari. Mbere yo gusezera umurwayi turabanza tukavuga tuti tugendeye ku bimenyetso, turabanza tukavuga tuti ni iminsi 10 byibuze tubara duhereye igihe ikimenyetso cya mbere cyaje. Iyo minsi tukayibara. Twarangiza tukareba ese ikimenyetso cya nyuma cyagiye ryari. Hari nk'umurwayi, dufate abarwayi babiri, umurwayi umwe ashobora kuba yaraje amaze iminsi 2 ibimenyetso bije. Dufashe umurwayi witwa A, yaje amaze iminsi 2 ibimenyetso bije. Uyu murwayi twise A afite umutwe, afite inkorora, afite no kubabara mu muhogo no gucika intege. Umutwe washize, ibimenyetso byarangiye nyuma y'iminsi 5 ari mu bitaro. Nitujya kubara ya minsi 10 bisabwa tuzabara ya minsi 2 kongereho iminsi 5 yamaze mu bitaro, ubwo habe hasigaye indi minsi 3. Kuri ya munsi wa 5 ibimenyetso bye byari byarangiye, izahura n'iminsi 7 ibimenyetso bye bigaragaye. Twongereho indi minsi 3 kugira ngo ibe iminsi 10. Ese uno muntu twamusohora tugomba kureba ikimenyetso cya nyuma cyagaragaye ryari. Cyagaragaye ku munsi wa 5 ari mu bitaro. Iyo tubaze atashye kuri uyu munsi wa 10 dufite hano, uyu muntu tumushatse twamucyura kuko iminsi 3 agomba kuba amaze nta bimenyetso afite irahagije. Ariko dufashe umuntu witwa B, tugasanga yaje afite ibimenyetso nk'ibya wa wundi bimaze iminsi 2 nawe bije, ariko arinze agera ku munsi wa 9 agifite ikimenyetso cya nyuma cyagiye ku munsi wa 9 ari mu bitaro. Ku munsi wa 9 ari mu bitaro. Ubwo turavuga yuko nitujya kubara ya minsi 10 isabwa hagati y'igihe ibimenyetso byatangiriye n'igihe byarangiriye, turasanga ahubwo iminsi 10 irenga, kuko iminsi 10 yagomba kugarukira ku munsi wa 8, kandi ku munsi wa 8 yari agifite ibimenyetso. Ni ukuvuga wa wundi umuntu witwa B ku munsi wa 10 ahuriraho na wa wundi witwa A, we azaba agifite ibimenyetso, ntabwo twamusezerera. Umunsi wa 9 nugera ibimenyetso bigashira, tuzaba indi minsi 3 tuzamusezerere. Ku munsi wa 12 aje mu bitaro, bizahura twongeyeho na ya minsi 2 yabanje ataragira mu bitaro, bibe iminsi 14. Icyo rero ni kimwe mu bintu bigaragaza yuko hari igihe abantu bashikira kwa muganga rimwe, ibimenyetso barabitangiriye rimwe, ariko umwe agataha mbere y'undi. Nuko muri bya bintu dukurikiza mbere yuko tubasezerera bataba barabihuje. Sinzi niba icyo kibazo ngisubije neza, murakoze.
Yes. Alan, can you go ahead with questions? Okay, Alan is unmute. Alan?
Yes. Thank you so much. Doctor, I think you'll go back to using English. Coco, there's a comment about using English because they don't understand. So
Okay.
the question was, I want some clarification on when to use a PCR and a rapid test. As Dr. Anita said that they have the same specificity, why does it require a PCR test to travel and not a rapid? Yeah, and there's also a question about using a rapid test for people having symptoms. I got lost. Clarifications, please.
Okay, thank you. The person asked why PCR is required for persons who are traveling. Sometimes persons who are traveling, they don't have symptoms. And we have said that when we perform a rapid test for a person who is asymptomatic, we will not have a good result. We will have several times a negative response. But when we are using a PCR on day 5 of exposure, even though we don't have symptoms, on day 5 it will be positive. That's why we use PCR for asymptomatic person. But rapid test and PCR test, they will be like equivalent when the patient has symptoms. That's when the specificity is equal for the two testings. Alan? Hello, Alan?
Alan? Okay. Alan is on mute. Excuse me.
Thank you. Yeah, so the other question was, how does a COVID-19 confirmed case after 7 days be declared negative while no treatment was given, only staying in home self-isolation?
Okay. If you have already seen my presentation, if you catch well, we have different categories. We have asymptomatic person who have been COVID positive. We have a mild patient who has symptoms, but those symptoms are simple. Those people, those two people, the asymptomatic person who have been COVID positive and the person who is symptomatic but with few symptoms, they go home for treatment based home. It means they go home, they stay in their room, the treatment is not required. For this one who has few symptoms, cough or fever, they give them paracetamol, piodoterin for congestion. They give them other treatment which is related to the symptom they have. And they stay home for control. The COVID-19 normally it doesn't require treatment. Our body is built at the way it can face the viruses. And when the body can face the viruses, that's the time you can get the COVID with no symptom, or you have some symptom, but they pass away in few days without treatment. Your body have done a great job for protecting you, and at a certain time, the viruses are unable to replicate, and when we have more than 10 days from testing for a patient who is asymptomatic, or 10 days after the onset symptoms, you can test the patient and you will find that there is no viruses in the respiratory tract, because our body has its capacity of fighting against anybody which is hurting our body. I think you understand the response. It's normal for a person who is asymptomatic or who has few symptoms to recover without treatment. And the treatment we give for those who are in ICU or in treatment centers, it's also symptomatic treatment and the treatment for complications. Because when we are treating a pneumonia or we are treating a shock septic or other thing, we are treating the complication of the COVID-19. We are not treating the COVID-19. Thank you.
Thank you so much. The other question is, I had exercise part of treatment. I had exercise as part of treatment modalities for patients with COVID-19, yet it's known that exercising when having flu-like disease won't be a good idea, as it can be a risk for myocarditis for some patients indeed. The following article is one of the evidence showing the risk to worsening the condition. Any study done so far in Rwanda. They also put the link below in the chat.
Can you repeat, please? I didn't. It was cutting.
Yeah, so the question is about I had exercise as part of treatment modalities for patients with COVID-19. Yet, there is an article that he read that shows that exercise is not good for people with flu because it can be used for myocarditis, something like that. So, do you have anything to say about exercises, doing exercises related to being it not being good for someone made?
Well, it is cutting. I didn't get well the question, but it's about exercise.
Okay, Doctor.
Which is not.
Mutirita. Yeah.
Yes.
Okay. Okay. Go ahead, please. It's about.
Okay. Hello?
Hello, the question is about exercise, like maybe an explanation of how exercises how they relate with someone having COVID-19 and how some articles do show that it is not good for someone to do exercises. Why do this? Hello, can you hear me?
Yeah, ntabwo ndi kukumva neza, biri gucikagurika.
Hello?
Oui. Okay, I've seen the question. I heard exercise is part of treatment modalities for patients. It's known that exercising when having flu-like disease won't be a good idea, as it can be a risk of myocarditis for some patients. The following is one of the evidence showing the risk of worsening the condition. There is no study, but in my practice, I'm going to give you an answer from my only experience. I think it's the contrary for what I see when you have a flu and you do exercise. You don't have to go and do exercise like a professional. No, just you can have.
Health-Edu host. Can you please mute?
Yeah, let me continue, please. Alan?
Yes, you can continue.
Okay, so,
Yeah,
I was saying that from my own experience, when a person have a flu and you perform exercise, it helps you to recover quickly. But I don't think it, when we talk about exercise, it doesn't mean you do a professional exercise. No, you have just to, you can have a jogging, a moderate physical activity, not a intensive physical activity, because even though it's a flu or another respiratory disease, we have also to consider our physical condition. You don't have to do beyond your capacity. A moderate physical activity is more recommended in those cases. But from my own experience and a study here in Rwanda, we have I don't know any study about exercise and the flu.
Okay, the other question is about, in terms of PPEs, last week I read an article about the impact of prolonged use of surgical masks. They highlighted that prolonged use of face masks to some people have become allergic, and some have developed runny nose, mostly in the morning, prolonged sneezing when they are awake. So, doctor, what could be the logic behind the developing of these allergies?
Those allergies. Well, it's possible there are many allergies on mask, especially on surgical mask. The logic which can be possible is that when we have a surgical mask, there are many products are used. That's what I think. There are products are used to give the color, to give the there are many things they can add, which is different from N95. N95 already it protected more allergy than surgical mask. And when you can see surgical mask, they protect for bacteria or for viruses, but when it comes for allergies, the percentage is low, which means that many people can have allergy on the surgical mask, depending on the product used in the manufacturing. That is what I think about the surgical mask.
Okay, on that question too.
But the N95,
yeah, you can continue.
but the N95 or FFP2, normally the allergic issues, they're not found in many cases.
Okay, so I think that can also answer a question that was, I have a friend who's a clinician too, and they've developed these allergies. So what is the best face mask that should be used then, since because the ones we use at the hospital are causing allergies?
On hospital, you use either a surgical mask. When you don't use a surgical mask, you can use N95 or FFP2 or FFP3. Those are the kind of mask you can use if you are allergic. But if you are allergic on surgical mask, those the N95 FFP2, they are not more allergic.
Okay, so they have some questions about abbreviations like what's PPE and what's IPC.
Okay. IPC, it means infection prevention control, and PPE, it's professional protector equipment. Voila. IPC, can I repeat? IPC, infection prevention and control. PPE, professional protector equipment. Personal, thanks. Personal protective equipment.
Okay. So
Very specific.
Alan,
I can
go
see
ahead.
some hands up. Maybe we can give 2 minutes to 6 to explain physical activity related to management to COVID. Hello?
Alan?
Hello, physical management.
Okay, I think I will read one of the questions here as we sort out that case. So what are the tests which are being used for the cases?
Okay.
For the cases we are recording on a daily basis, are they rapid tests? If yes, what are the accuracy? Looks like they are testing the mass and most of them don't have symptoms. Don't you think the results will be biased?
That's why before the testing, the control testing, first it was done by PCR. Yes, actually you can also do with the antigen testing for control, because generally the control is done on the 7th or 10th day after the first testing, and it is, even though the rapid test is negative and you think that it's not yet negative, the thing that we have to notice is that when we release a patient, is that patient is able to transmit the disease? This is the question. And it is been found that since the 7th day after the onset of symptoms or the 7th day of the testing, the positive testing, the viral load starts to reduce, have been reduced, and the viruses which remain, they don't have the capacity of replication. And when there is no replication, there is no transmission to other people. That's why even though the patient is discharged, we recommend them to continue isolation at least 7 days, and to continue to observe IPC measures, washing hands and putting mask, using the proper dishes, stay at a distance with other people for at least 7 days, and then there we are sure that the person is more or less cleared from the viral load of virus. But even though the PCR is negative, it doesn't mean that all viruses there is no viruses for that person. It may be there is a value they use in laboratory. I think when they do amplification viruses, they go to 30 value. I don't remember well, but when you are under 30, they consider you as negative and you can go back home. At this level of 30, replication of viruses, you cannot transmit those viruses to other person. That's why when they discharge a person, they tell him, go back home, stay home for a week or 2 weeks, and continue to observe all IPC measures we've told you, and then after you will come back in the normal life. So when they use the antigen testing, it's just to see if there is already an antigen. When the viruses reduced, even the antigen is absent. That's why when we do a negative test on rapid test or on antigen test, it means also that the viruses have been reduced. Thank you.
Thank you so much. I can see 2 hands up. Maybe we should let one by one ask the question. So, Keys, if you could allow Galaxy Tab A 2016 to ask.
Yes. Yeah, he's on mute. You can ask your question. Galaxy Tab, who is this one? Galaxy Tab A 2016. You can ask your question. Okay. Yes, you can mute him and then unmute user 2020.
Yeah, user 2020. User 2020. Keys, can you please unmute user 2020?
So he's asked to unmute himself if he didn't click on the button.
Yeah. He's unmuted.
Okay. Okay. So you can maybe mute
User
them.
2020. Okay.
Okay, so the other question is, on which percentage of effectiveness of these masks for most people use in daily life? Hello, Dr. Anita. There is a question in the chat.
Can you repeat it?
Yeah, there is a question in the chat on which percent of effectiveness of these masks, especially the ones that people sew for themselves, most of the people use them in daily life.
I don't catch the question.
So the question is on which percentage of effectiveness of these masks most people use. Ndakeka izo zindi zimwe zidoze zimwe
Okay. Yes. Okay.
How effective are they?
Those masks, clinically, they are not bon. According to what I know, they don't protect below 5% from viruses. Above, they don't protect above 5%. So for me, those masks, they don't effective for protecting people for COVID-19. But because we know COVID-19 is a virus which is among of big viruses and is vehiculated in airborne, and in this airborne, either in airborne and droplet. So when we wear those kind of masks, when I'm talking to people, I project less droplets from saliva. When I sneeze, I project less droplets in the air. So these masks help us to reduce the projection of droplets in the air. And when we wear also, we cannot catch droplets from the air because it helps. But to protect from viruses only, they don't protect beyond 5%. So we can wear this mask, but not in health services or in health facilities. When you are at hospital, clinic, pharmacy, better you wear surgical mask N95. When you wear a tissue mask, you are exposed because the tissue can be ishobora kujyaho amacanjwe igatota, and when it is iyo yatose, it's easy for the viruses to go in your respiratory tract. So better use surgical mask and N95. But when you are outside in the places with other people, when you are not immediately in contact of probable cases or suspected cases, you can wear a tissue mask because it protects you from contact with droplets which are in the air, and you reduce the projection of droplets in the air.
Thank you so much. Thank you so much. I think we can unmute. She's already unmute. Daisy Umutoni to ask.
Yeah, I asked a question earlier, so I'll repeat it about the discharge criteria. So you say that there is the symptom-based, and then there is the PCR test, the test-based. So I'm wondering what is, I don't know if I missed, maybe you talked about it and I missed it. How do you decide who to test, or just to follow the clinical picture of the patient before discharge? What is the criteria? Thank you.
Okay. The two criteria are complementary. For example, when we have a patient who has been, for example, in hospital for 10 days, And when you do a test, the test came positive. On the 10th day, after the test, after the onset of symptoms. And when you calculate, because we are dealing with a person who have symptoms, and when you calculate, you count also 3 days without symptoms. As I've said, sometimes you can do PCR. PCR is more sensitive than rapid. When you've done PCR, and it come back positive, already the patient has completed the 10 days since the onset of symptom, and you have also 3 days without symptoms. We go back to what I've told just a few minutes ago. I've said that the replication of virus can be is not effective during these periods. So I can take a decision to discharge this patient, although the test has been positive, when, for example, we have a cloud of patients and we don't have enough places in hospital. But for example, it have been days where we had more patients in treatment center, and the capacity, the bed capacity was exceeded, and we can't put 2 patients on the same bed. So we can decide for those patients, even though the control tests have been positive, we can see if these clinical criteria are respected. We can take a decision to discharge them and continue the follow-up at home. Because this one is more or less like as a patient who took his treatment or who took his observation at home when we diagnose that patient. For example, when a patient is asymptomatic, we tell him, go back home, go in your room, stay there, do this, don't do that. It's the same. This patient can also discharge him, even though the test is still positive. We know that the transmission for this patient is low, so he can go back home and recommend him to stay in his room, come back at a certain time for retesting and following him. That's what we can do. So those criteria can be applied. They are complementary, but it helps sometimes to take some decisions when there is no place, but when you have 10 places, 10 beds, and you still have a patient who is positive, I think it's also better you stay with that patient till he will be negative on testing. But when it's not possible, you can use the symptom-based criteria to discharge that person and still follow that person at home until the last testing will be negative. Are you okay?
All right. Can we unmute Ben Honore to ask a question? Case? Ben Honore? Ben Honore is not. Case? Did you say? All right. Okay. Go ahead.
I want to know the effectiveness of CPLR compared with the rapid test.
Mm-hmm. You say, what is the difference?
the effectiveness in terms of percentage?
I'm not sure, but it's below. The effectiveness for the two tests are the same when the patients they have symptoms. Effectiveness is the same either PCR and rapid tests, and the effectiveness is above 90%. I don't remember exactly the number, but it's above 90%.
All right. Okay. I've Alan.
Yes.
Do you have some other questions?
Yeah. A question from YouTube. Why are people diagnosed with COVID-19 with no fever and no cough?
Why we can diagnose COVID-19 without fever and cough? That's the question.
Yes.
Yes. If we go back on the clinical presentation, you can see that a patient is suspected. When we talk about a suspected patient, it's a person who is fever and or cough or shortness of breathing or other of congestion or fatigue or other symptoms, right? And I've said that sometimes person they have fever. That's why here when we say fever, it's found in 83 to 99% person. It means that there are persons that you will not find fever. But when you go in history, the person will tell you 2 days before I had fever and I took paracetamol or ibuprofen, but I still feel fatigue and headache and I have congestion. You see that person doesn't have cough, there is no fever, but he has no specific symptoms. He has congestion, he has headache, he has also fatigue. That person who took paracetamol, somehow it hides the fever. That paracetamol or ibuprofen the person took had hidden the fever. So when we are asking people, we can ask them if they didn't take any medications for fever or for headache. Sometimes those treatments hide fever. And sometimes the patient, as I said, it depends on the personal condition. When you are facing a immunosuppressed patient or in old people, you will not see fever, you will not see cough, perhaps you will see atypical symptoms. That's why when you are assessing a patient, you have to know the comorbidities, and according to the comorbidities and the person to whom you facing, you have to think of each symptom we have related here. Even though there are persons who will come with loss of appetite or loss of smell, and when you push the assessment and the interrogatory, you will see that they had some symptoms, but they took some medication in the pharmacy. So sometimes the symptom the patient came with, you have to search for other symptoms but also we can have asymptomatic patient. We cannot forget those persons. There are persons who can be asymptomatic, and there are so many, and they are COVID-19 positive. So it's possible. You have one symptom from those who have also a non-specific or atypic symptom or you have no symptom and you have COVID. All is possible.
Okay, thank you so much, Dr. Anita, for the lecture, for the answers. I would also like
Thank
to thank
you.
everyone that participated in asking questions. It is really good if the audience is also participating. I would also like to thank Daisy Umutoni, Healthcare, Dr. Leonce is also on, and other doctors that have been able and to answer questions in the chat box that were asked. Thank you so much. Thank you again, Dr. Anita, for the lecture.
Thank you.
And I think we'll meet again on 2nd. I'd like to invite Mr. Jean Damascene to give us the guidelines for the next lecture. Thank you, everyone.
Thank you very much, Alan, and thank you very much, Dr. Anita, for the presentation and the responses on questions. And let me thank again Dr. Daisy and so many other people who have tried to help in answering these questions. Now we are at the end of day 2. We are going to have another session on day 3, which is 2nd of Feb. So tomorrow we are having a break, and Monday is the 1st February, the Heroes Day. So we are going to meet again on the 2nd of February, and we will be having a session on contact tracing. So we've been hearing about contact tracing, how it's done, how it started, and how it's being done currently. So we are going to have everything about that with Dr. Jimmy. Oh yeah, and yeah, that's it. So we cannot. It's not possible for us to host many people. That's why we created that YouTube channel. So people who are not able to join can use the YouTube channel, and then as well questions have been answered here. So that's it. And just to remind you, this is being done under the partnership between Rwanda Healthcare Federation, which is supporting these activities, and it's on the rationale that public health facilities have been leading the fight against COVID-19, and Rwanda Healthcare Federation is now strengthening the private and members of its members to get necessary skills and information to join the battle. So this is it as we move, and there are so many other projects, like a project on infographics that's being implemented by Rwanda Healthcare Federation, and there is a research project which is the assessment of preparedness and response to COVID-19 being done by Rwanda Healthcare Federation. But this concerns the East African countries. Yeah, that's it for now, and we hope that at the last day, on day 4, we are going to have the chairperson of Rwanda Healthcare Federation for a closing remarks, or the vice chair. We've been asking people to name themselves here. There are a lot of people, so when we get the report, the Zoom report of a dairy attendance, we don't find their names. So we could ask you to try that, so that on day 3 at least, we may get the proper names. So thank you very much for the attendance, and the materials will be shared. Thank you.
Thank you.